Thank you for allowing me to contribute to your conference. I'm very excited about the topics that you're addressing today. I'm going to be talking on the Choosing Wisely campaign, which is an ABIM Foundation initiative designed to catalyze conversations between physicians and their patients about the risk and burden of overuse of diagnostic tests and treatment. My name is Dr. Catherine Lucy. I'm the Vice Dean for Education at the UCSF School of Medicine, and I'm also a trustee of the American Board of Internal Medicine Foundation, who is sponsoring this initiative. In 2002, the ABIM Foundation joined with the American College of Physicians and the European Foundation of Internal Medicine to publish a physician charter, a millennial approach to professionalism. Included in this charter were many of the professionalism values and tenets that have been held dear for centuries, since the time of Hippocrates. But new in this charter were two new elements. One was a commitment to the physician's responsibility to address issues of social justice, like access to care and eliminating disparities of care, and also a commitment on the part of physicians to attend to the just distribution of finite resources. In 2010, the controversy around the passage of the Affordable Care Act and much of the rhetoric that was moving around the airwaves, such as death panels and rationing, caused the ABIM Foundation to take a critical look at the charter and identify ways to help physicians deal with the issues of stewardship of valuable resources. We all know that, in fact, the U.S. healthcare system is very expensive. We spend more per capita in the United States than any other of our peer institutions in the OECD. And the value we get is not as high as we'd like. This slide illustrates that we are last in those OECD countries in calculation of mortality amenable to healthcare. Even more alarming than the current costs and the relatively low value of healthcare in the United States is the anticipated continued growth of healthcare expenditures. If healthcare expenditures hit the 20% of GDP mark that it is estimated to hit by 2020, healthcare expenditures will begin to interfere with our ability to pay for other aspects of social good that impact the social determinants of health, for instance, education, public safety, and environmental issues. When we look closely at the causes of that acceleration of healthcare expenditures, we find that waste, defined as overtreatment or duplicative treatment, comprises about a third of anticipated overexpenditures on health. That's a third of a $2.7 trillion industry that is lost merely due to overtreatment, including unnecessary prescription of drugs or diagnostic tests, and failure to coordinate care that leads to duplication of tests and treatments. So why should physicians be the ones that address these issues? Why not let this be dealt with at a payer and a governmental perspective? Well, there's a pragmatic perspective that we felt needs attention. The first is that physician decisions account for 80% of all healthcare expenditures. Many have said that the most expensive diagnostic tool we have in our armamentarium is the physician's pen, or in today's environment, the physician's keyboard. Secondly, we find that over a third of physicians, when queried, and this is the result of a national survey of physicians done by Eric Campbell in 2007, said that they do, in fact, acquiesce to patient requests for tests or treatment even when they're not clearly indicated. But physicians have a role in stewarding valuable resources and finite resources that's professional in nature. And this reflects back on the charter as published in 2002. Adhering to those principles and commitments articulated in that charter requires that physicians use their competence, use their commitment to quality, use their oath to be honest with their patients, and use their best evidence produced in the United States and elsewhere today to direct the appropriate use of healthcare resources. It is part of the way in which we live professionalism. And secondly, patients trust physicians because they are professionals. They trust us to guide them in making wise choices about tests and treatments that may not help and may actually even potentially harm them. So waste, overtreatment, and duplicative tests in the U.S. healthcare system, there are very complex problems. We realize, in fact, that they have many, many etiologies and that the solutions will need to be shared by many different populations. But we think physicians and the profession can drive this solution. But our first bit of work in the ABIM Foundation was to try and get a handle on why overuse occurs. What were the drivers of unnecessary diagnostic and therapeutics? First and foremost is worry and uncertainty. Patients come to us worried about a symptom, what it might represent. Could it be a serious illness as opposed to something minor? And they expect us to use all of the diagnostic and therapeutic options that we have in front of us to help ease their burden of suffering or cure the disease that they might be subject to. Physicians worry as well. They worry that perhaps their clinical evaluation is not sensitive enough or specific enough to target the real cause of a patient's symptom, and they're worried that they might miss something that is more treatable now than would be if they simply watch and wait for it to be more clear in the future. Patient satisfaction is another driver of unnecessary diagnostic and therapeutics. We are all susceptible to being measured in the ways in which we satisfy our patients and meet their needs, whether at an institutional level or an internet-based level, as more and more people are posting opinions about doctors on Yelp and Angie's List. And we often find it more satisfying to patients if they leave our office with a prescription or a diagnostic test, and that's a driver of waste in the healthcare system. It may be easier to order a diagnostic test or treatment, and certainly faster, than taking the time to explain the evidence behind not doing that test or treatment. The risks of some of these diagnostic tests and treatment may be hidden, may be invisible today because they may not be apparent for decades down the road, such as the case with cumulative radiation exposure. And costs are a conundrum. It is virtually impossible for any of us sitting in our office or sitting in an integrated healthcare system to really know how much a test is going to cost the system, and even more importantly, how much it will cost your patient in terms of out-of-pocket costs. Risk management, a commonly cited cause for driving unnecessary tests and treatment. People who are concerned that they might be sued because they overlooked a diagnosis are another source of drivers of overutilization. And finally, all of this speaks to a culture of more is better. In the U.S. healthcare system, we believe that more care represents the best care, and that comes not only from our patients and our peers, but from many of the people in the environment who can't believe that actually errors of commission are sometimes as bad as errors of omission. But each of these things can be refuted. Each of these drivers can be refuted intellectually if we really step back and sort of say, if we needed to tackle the problem of overuse, what would we tackle? Elimination of uncertainty in healthcare is impossible. There is no perfect test that will tell us that this patient is perfectly healthy and will never suffer from something if we don't find it today. Patient autonomy is not absolute. We want our patients to be satisfied, but we can't expect that patients are going to be able to demand any test or treatment just because it exists. They have to be informed, and they have to have understanding of that information in order to make decisions that allow them to exercise that autonomy. Benign diagnostic tests and treatments may not be. All of us have had the experience of prescribing a simple antibiotic and the patient ending up with C. diff colitis, or as we talked about briefly, the problem that's becoming increasingly apparent in the radiology field is the harm of cumulative radiation exposure due to excessive scanning. Covered tests and treatments can still cause bankruptcy. Over 60% of people who file for bankruptcy do so because of high healthcare costs, and that's true even in elderly patients who have Medicare as their backup. And finally, I think all of us recognize that more healthcare is not better. Better healthcare is better, and this is where the profession can step in and provide some guidance. So the ABIM Foundation in 2010 was looking for a way to address stewardship in a way that respected the expertise of the profession and actually supported the professionalism of individuals as they care for individual patients. And we were very intrigued by this article written by Howard Brody on medical's ethical responsibility for healthcare reform, the top 5 list, excuse me. This was published in the New England Journal in 2010 and attempted to move the rhetoric about rationing, that is, denying someone care that's truly needed, away from the conversation that we were having in the healthcare reform environment, and instead turn to a question of waste reduction. And waste reduction, in contrast to rationing, is not doing things that are not going to help people and could potentially harm them. So we were really intrigued by this, and in fact, the National Physicians Alliance came to us and we supported a grant that allowed them to charge a working group to develop top 5 lists in primary care specialties. And this top 5 list in family medicine, pediatrics, and internal medicine was published in the Archives of Internal Medicine in 2011 and immediately began attracting attention as people said there are things within our environment that we can stop doing that will both improve the quality of care by removing the possibility of unnecessary harm and also save money for the healthcare system and our patients alike. And in fact, a subsequent article also published in the Archives of Internal Medicine, now known as JAMA Internal Medicine, estimated that if all of the tests and treatments articulated in the top 5 list for primary care, internal medicine, family medicine, and pediatrics, were operationalized across the country, the savings to the U.S. healthcare system would be approximately $5 billion, with a B, dollars. So recognizing kind of a groundswell of interest in this approach and also understanding that it capitalized on what we think is most important, that is the profession taking responsibility for the profession and for guiding patients in making wise decisions. The ABIM Foundation, combined with physician specialty organizations and Consumer Reports and some other consumer organizations, to develop the Choosing Wisely campaign. This is a campaign we've described as being of the profession and for the public. Importantly, it's an initiative designed to promote conversations not between the government and physicians or between payers and physicians, but between physicians and patients. And these conversations were directed to be about utilizing the most appropriate tests and treatments and avoiding care that is not likely to benefit and may harm some individuals. There were 3 components of the campaign that were critically important and have been critically important to its success. The first is to clarify a purpose-driven message. Doctors want to do what is right for both their patients and our society, and eliminating waste is not rationing. It's not rationing. Eliminating waste is good medicine. Secondly, we wanted to catalyze physician organizations to take the lead. This is the of the profession. Experts should guide recommendations about what tests and treatments are overused and therefore should be considered for lesser frequency use. We wanted to avoid, very carefully avoid, the possibility that these lists would come from payers or government and would actually be translated into what we call never-do lists. These were supposed to be lists about what we might do less of. And thirdly, we wanted to engage the consumers and public. This is for the public part of the equation. We realized that the culture of medicine where more is better, where patient satisfaction is driving some of the overtreatment and overutilization of diagnostic tests, could not be changed by physicians alone. We wanted to also to gradually change the expectations of patients about what is high-quality health care. And we knew that we would have to engage consumer groups to help us get that message out. Now, when we went to physician specialty organizations, we were surprised at the rapid uptake of this idea. And from the very beginning, we've had dozens of specialty organizations interested in working with us, starting with the first 9 in 2012, and an additional 17 will be released this week. We went to the physician societies and said, you're free to choose the process by which you determine what should be on your top 5 list. But there were certain criteria we asked them to adhere to, and they have done a wonderful job at this. First, every item on the top 5 list had to be within a specialty's purview and control. We didn't want them pointing fingers at other specialties, sort of saying, well, we'd be fine as long as these other type of doctors would change the way they manage their healthcare issues. Secondly, we wanted them to choose procedures that were used frequently, or if they were not used that frequently, something that incurred a substantial cost to the patient and to the system. Thirdly, there needed to be generally accepted evidence to support each recommendation, and the process to identify and vet the recommendation should be able to be thoroughly documented and publicly available upon request. And finally, each recommendation needed to focus not only on expense, but on the lack of benefit of the procedure to certain populations of patients and the risk of harm to some individuals. So the 5 things physicians and patients should question from the American College of Radiology include things like, don't do a CT scan for pulmonary embolus if the patient has a lower than moderate possibility clinically of having a pulmonary embolus. It recommends not following up on benign physiologic cysts in reproductive age women. It looks at issues of delaying CT or avoiding CT unless an ultrasound has been done in children. And it recommends against radiologic imaging for patients with uncomplicated headache. All of these things because they have been shown by evidence to have low value and actually may incur risk associated with cumulative radiation exposure. I'm going to review some of the more radiology-centric recommendations from other specialty societies. And again, this was not about asking radiologists to do less, but asking the people who prescribe for radiologic diagnostic tests to rethink whether they're needed in every situation in which they're commonly used. So the American College of Physicians don't obtain imaging studies in patients with nonspecific low back pain. And again, what's highlighted here is an example of the justification for this included in the top 5 list. And at the bottom you can say, because these CT scans do not improve patient outcomes. So very important, this focus on either evidence that shows that patient outcomes are not increased when these tests are used in a broad population, or that they might cause harm. The American Academy of Pediatrics. CT scans are not necessary in the immediate evaluation of minor head injuries. Clinical observation, pediatric emergency care, applied research network, or PCARN criteria should be used to determine whether imaging is indicated. So this is a perfect example of guiding people to use a clinical risk score to decide whether or not imaging is required, rather than perhaps responding to a patient's or a physician's concern about, a patient's concern about whether a CT should be ordered. And again, the rationale is that unnecessary exposure to X-rays poses considerable danger to children, including increasing the lifetime risk of cancer. The statistics are pretty shocking. About 50% of children who appear in emergency departments across the country with minor head injuries receive a CT scan. And so the amount of X-ray exposure might be significant. So American Gastroenterological Association. For a patient with functional abdominal pain, as per Rome 3 criteria, again, recommending people turn to clinical decision tools rather than gut instincts. CT scans should not be repeated unless there is a major change in the clinical findings or symptoms, because there is a small but measurable increase in one's cancer risk from X-ray exposure. And again, each of these lists detail either the lack of evidence-based benefit or the presence of an evidence-based risk, or both sometimes. Importantly, the American Society of Clinical Oncology came out with some very powerful recommendations for early-stage breast cancer and early-stage prostate cancer, and this one pertains to breast cancer. Don't perform PET scan, CT scan, and radionuclide bone scans in the staging of early breast cancer at low risk for metastases. And again, using clinical practice guidelines, you can estimate the risk for metastases for the patient in front of you. And as they articulate, unnecessary imaging can lead to harm through certainly unnecessary radiation exposure, but also harm because of unnecessary and follow-up invasive procedures, overtreatment, and misdiagnosis. So it speaks not only to the direct harm of overtesting and treating, but also the downstream harm of overtesting and treating. Since the start of this campaign, we've encouraged specialty societies to come on board when they're ready to come on board. And the first group of pioneer Choosing Wisely specialty societies came on board in the spring of 2012. And they included the American Academy of Allergy and Immunology, the American Academy of Family Physicians, the American College of Cardiology and the American College of Physicians, the American College of Radiology, the American Gastroenterological Association, the American Society of Clinical Oncology, the Society of Nephrology, and the Society of Nuclear Cardiology. The second phase of Choosing Wisely partners will come on board on February 21st. And they include a huge number of specialty societies, including specialty societies in fields of surgery. And then the next phase will occur sometime later in 2013 when additional specialty societies will come on board. People have asked, why do we phase in this program? Why didn't we launch them all at the same time? We really wanted to pay attention to the process needed by each of these societies to engage their physicians in a rational conversation about what policies and procedures, what tests and treatments might be overused, and what recommendations might be put forth from that society that could be endorsed by its members. So accuracy and buy-in was more important to us than timing, and we are grateful that all of these specialty societies have put forth the effort necessary to join this important campaign. Consumer Reports has been a wonderful partner in this. They have published a number of different articles in Consumer Reports that address this Choosing Wisely campaign and talk to patients about the dangers of overuse. And I love this phrase, when to say whoa to doctors. And this article, among many of them, talk about when is it necessary or not necessary to have a specific diagnostic tests. They also emphasize the importance of having a conversation with your patient to see where you fit in the spectrum of somebody who clearly needs a test versus someone who clearly doesn't need the test. And Consumer Reports is working to engage employer groups to also help them get the word out to their employees so that their members can have access to this information at their fingertips, whether or not they are lifelong members of Consumer Reports. So what's next? We recognize that doing the list is just the first step. What's now has to come is the hard work within the exam rooms, in the emergency room, on the hospital wards, where patients have these conversations with their physicians and where physicians can guide their patients in shared decision-making that's evidence-based and incorporates patient values and does not expose them to unnecessary risks or burdens of the questionable tests and treatments that these lists articulate. So Drexel University has been working on a series of communication videos to help people address and deal with these fairly complex conversations. We are working with our partners in the training environment, both medical schools through the AAMC and residency programs through the ACGME and other specialty organizations focused on physician training to help them think about what changing the training environment might look like if we expect to graduate a generation of physicians who pay attention to cost and stewardship of valuable resources. And lastly, we want to catalyze others to join the campaign. The best way to participate in this campaign is as a group. So we want to reach out to individual office practices as well as integrated healthcare systems who sometimes have policies and procedures in place that make overuse easier to follow than appropriate use. Those of you who are interested in more information can follow the Choosing Wisely website, www.choosingwisely.org. Follow the medical professionalism blog that's on the ABIM Foundation website. Or those of you who are more instant messaging adept can follow us on Twitter and Facebook. So thank you very much for allowing me to participate in your conference, and I wish you the best as you try and tackle some of these very difficult problems on behalf of our profession and our public.